And thank you all the doctors who joined me on Friday evening during this COVID emergency time on this webinar from all over the Gujarat. So what I'm going to talk about the managing diabetes in current pandemic of COVID, and I'm sure all of you would like to know that how best we can treat our diabetic patients during this pandemic situation. Can I have next slide? So we'll be talking about this COVID 2019 situation where we will be managing diabetes, how to deal with diabetic patients. My disclaimer is very clear that because this is an emerging and rapidly evolving situation. So I'm trying and we are going to put all those latest data which we have till today, but still because it's an emerging and rapidly evolving situation and we are focusing primarily on WHO and ICMR guidelines, but still there's a possibility that you may have some new data which may emerge tomorrow. Next. Now, this is really a whistleblower. I'm sure many of you must have seen this doctor, Dr. Lee, who died, a very young doctor, 34-year-old only. He is by profession ophthalmologist, but he alarmed his fellow doctors on a chat group that he noticed some 7 cases of virus and which he thought looked like SARS in presentation. This is very interesting, and this he told long back. Next slide. So what is this 2019 novel coronavirus? This is what COVID 2019. It is novel because it is not the routine, because before that also a similar type of virus was there, SARS-CoV, that's coronavirus, was causing SARS, which was in China again in 2003. Then we have MERS-CoV, which was in Saudi Arabia in 2012. And this new coronavirus, a novel coronavirus, which was in 2019 in China and now all over the world. So now we can't say only in China, it is all over the world. And hundreds of cases spread within the China and now almost all over the world. Now this primarily this coronavirus, if you see, it is circulate in range of animals, not only the bat, but there are range of animals where it is getting circulated. And this coronavirus is because there are multiple spikes on a envelope, and that's the reason it is known as coronavirus. Coronation mean, it's like a Taj. So that genetic material, which is RNA, then there is an envelope, and above that there is a protein spikes which are there, and this making is like a crown, and that's the reason it is known as coronavirus. It is a respiratory infectious virus which leads to, because we know there are many respiratory virus which leads to common cold and pneumonia, but this is also a virus which is primarily affecting the respiratory system. Next. The structure and types, it is coronavirus, as I already told you, it's like crown-like spikes on their surface. Human coronavirus were first identified in mid-1960. So people were thinking that this coronavirus had come. It means it is completely new virus. Nobody was knowing about corona. It's not like that, because since 1960, we were knowing about the coronavirus, and many of us, even in our virology book, it was there. There are 7 coronavirus that can infect people. So the first one was alpha, then alpha corona again in a NL63. Then there is a beta. Beta were again in the 2 form OC43 and HKU1. Then there is a MERS, which is a coronavirus, a beta coronavirus, which causing Middle East respiratory syndrome. So because it was from Saudi Arabia, that's the reason it was called as a Middle East respiratory syndrome. But primarily it was a coronavirus, which was a beta coronavirus. Then we have a SARS, which was a severe acute respiratory syndrome. I'm sure many of you know about the SARS, and this was again a coronavirus. But this novel coronavirus, which had come from the China in 2019, so there are different 7 varieties of coronavirus which was identified, and we know from coronavirus from mid-1960. Next. The mapping in December 31st, 2019, WHO informed of an outbreak of a pneumonia of unknown cause detected in Wuhan city, Hubei province, China, which is 7th largest city in China with almost 11 million residents. So it is quite a big city where it was informed by WHO that there is a a pneumonia of a unknown cause. First reported infected individuals, some of whom showed symptoms as early as in December 8. So, I mean, as I told you, the first doctor who had talked about in his chat box, it was almost like in December 8. What discovered to among a stallholders from the Wuhan, South China seafood market, and subsequently that market was closed on 1st January 2020. It is not 10, it was 2020. So when 31st December 2019, the WHO had informed that there is a pneumonia of unknown origin, then at that time it was sold, and on 1st January they told that this market is to be stopped. January 10, this gene sequencing further determined it to be the new Wuhan coronavirus, and on that day it was named as a 2019 new coronavirus or novel coronavirus, a beta coronavirus related to the Middle East respiratory syndrome like MERS-CoV or severe acute respiratory syndrome like SARS-CoV. However, the mortality and transmissibility of 2019 new coronavirus or novel coronavirus are still unknown and likely to vary from those of the prior reference coronavirus. So we don't know if this is a novel coronavirus, but it will have a different mortality, and the transmission of this virus will be also different. It will not be like MERS or it will not be like SARS-CoV. The next slide. Now, the coronavirus, what are the signs and symptoms? And this is, I'm sure many of you must have read it, that coughing and fever, which is very, very important. And in severe cases, we get the shortness of breath and pneumonia. These are the very important 4 cardinal symptoms. You can say cough and fever with mild to moderate cases. And when they become severe, they may have pneumonia and shortness of breath. But those patients, they may have some atypical symptoms like vomiting and diarrhea also. And in advanced case, when patients in ICU in severe pneumonia, patient may have multi-organ system failure as well as renal failure also. There are severe symptoms are high fever, pneumonia, and then these patients will have kidney failure before they die. So the common symptoms are very commonly known: fever and cough, but otherwise the patient have breathing difficulty, and some patients may have GI disturbance and even diarrhea also. The next. Now, how to differentiate between cold, flu, and coronavirus? And this is very, very important, because when to suspect COVID. But at the same time, because you may not suspect some patients COVID because they may have atypical symptom also. So at this point of time in COVID epidemic, even a patients of cold and flu also to be examined with a high index of suspicion of corona. But yes, definitely there is a difference between a cold, flu, and coronavirus. One of the biggest difference is patients of corona, they normally catch the virus and beginning of the symptoms may be delayed. And this is one of the important reasons. Many of asymptomatic individuals also are infecting other people. This is very, very important. The symptom onset are very, very gradual, while in flu it will be very abrupt. Yesterday night patient was absolutely fine. Next day morning patient feels symptomatic, which is more common with a common flu, while coronavirus will have a gradual. How long symptoms may last? Now, mild patients will have a symptoms almost for 2 weeks, while patients who have severe or they may require hospitalization, even they may come out, but it may take between 3 to 6 weeks and commonly up to 6 weeks. Fever is very, very common. The running nose and sore throat are less common. And which is why we are seeing a lot of patients on telephonically, they call to us and they have a symptoms of typically flu or cold, which is very common. They have sore throat or they may have a running nose also. Now, cough is very common with corona, but cough may be common with cold also. The body ache is more with flu. It's like a viral type of fever, which commonly our patients tell us that they have a body ache, and difficulty in breathing is very, very typical of coronavirus. So I think if we can differentiate on the clinical symptoms, because many of our patients at this point of time when we are doing telemedicine, when we are just talking to the patients or patient is only on phone, you can ask the patient symptomatology, how patient had developed, what is the symptoms, what he has complained, and according to that complaint, you can decide that this patient may have a flu, cold, or even he may have a corona also. But still, we must have a high index of suspicion for all those patients, particularly who have a travel history or all those patients who have traveled in a in a crowded area where 200, 400, 500 persons were there, or they travel a place where there was a coronavirus was there, or they have direct exposure with some COVID patient positive. Thank you. Next. So the coronavirus, as per WHO report, which is a situation report, which we could get from on 2nd April. So I mean, on today only by 10 a.m., that no new countries. So whatever the countries which has been already reported with corona, in last 24 hours, there is no new countries been having a corona. This is very, very important. And our understanding is continuously improving, evolving over this outbreak. So I mean, WHO is also trying to learn, and all countries, all even ICMR, everybody is trying to learn that how it is happening, what is the way, how it is transmission is going on, and improving on the evolution of this outbreak. WHO is working with Iraq to increase the surveillance, because we found very high number of patients in Iran, but that not many patients with Iraq. The WHO is also working for a personal protective equipment and laboratory test kits, because many parts of the world, the PPE and laboratory test kits are not available. WHO is also working with government and partner all over the world to help the many countries, those who don't have the laboratory test kits, or they don't have the proper health professionals. So all those things, WHO is working hard with all these governments and trying to supply PPE, laboratory test kits, or even health professionals, the masks, sanitizers, and many more things to all over the world. Next. Now, this is the current situation which we have just taken. If you can see here, the last updated time is 4th April. It is today only at 2:41. So exactly before 3 hours, almost like 2 hours, we could update this slide. And what we had seen, the total confirmed patient had gone above 1 million. So this is very important. I think now we crossed 1 million patients all over the world. I mean, these were the confirmed cases with COVID. If you see the US alone, which is, China is now on a 5th condition. We have US, Italy, Spain, and even Germany. Yesterday till that, Germany was 5th, while China was 4th, but now Germany is having higher number of patients in compared to even China. More than 1 lakh patients are already there in Spain and Italy, and US has crossed more than 2 lakhs. And we don't know how France and Iran and United Kingdom, they are also moving very fast. So we don't know, maybe in another week time, we may find the China maybe on 7th or 8th position, and we may find many more countries who have higher patients in compared to the China. Next. Now, status in India. Again, this is the slide which is we have taken before 2 days. So on that day, it was 1,860 active cases, and now we have more than 2,500 till today afternoon. But this 1,860 are active cases. But if you see, the death is around 53, which is not very high in our country. But all those patients who died are mostly, they are male, they have comorbid condition. Diabetes is very commonly present in these patients, and more or less they were also elderly patients. Next. The definition, the SARI is a definition of patient with COVID-19 and an acute respiratory syndrome with history of fever, when the fever is more than 38 degrees, with the patients have a cough, and onset is within last 10 days, and they require hospitalization. In a person, SARI in a person with a history of fever and cough requiring admission to hospital with no other etiology that fully explain the clinical presentation. Now, what if a patient is having fever, but you don't get any other place where patient is having infection? It means there is no soft tissue infection, there is no infection on a skin, or you don't find any abscess or anywhere else which can lead to this high grade fever. So I mean, a suspicion become for COVID. A history of international travel, this is very important in the patients who have a travel history, which is to be taken very, very important. And a disease which can occur to a healthcare worker, because he is taking care of directly patients of COVID, and then there is a possibility that aerosol which are generated because of the patients who are having acute respiratory infection, he may have direct infection. A person may develop an unusual or unexpected clinical course also. So it's not necessarily that all these patients will have a typical clinical course. As I'm telling you already, this is a new infection and we are learning more and more. So we may get some other type of variety of presentation, but most of these patients have history of cough and high grade fever, especially in sudden deterioration despite appropriate treatment without regard to place of residence or history of travel. If another etiology has been identified, that fully explains the clinical presentation. So unlike you have a other clinical presentation, you have to understand at this point of time, if any patient with fever, you think of COVID unless prove otherwise. The next slide. A person with acute respiratory illness of any degree of severity within 14 days of onset of illness who have a close physical contact with a confirmed case of COVID-19. So there is possibility that patient may not have a direct getting, he may not have the history of travel, but their children or their directly somebody who is related and they have a history of travel. Even that may be the reason for this particular patient to develop the infection. Also, or a person who is working in a healthcare facility or a hospital where COVID infection patients have been reported. So these are the patients you should have high suspicion, and these patients should be tested for COVID 2019. Next. The close contact is defined very clearly. Those patients who are in direct care, who have direct exposure, working together in a close proximity or in the patient. So like suppose somebody was not knowing that he is a patient of COVID. After 5 days, patient was diagnosed. One of them was diagnosed in COVID, but other 15 or 10 or 20 persons who are working with him or traveling with him or living in the same household, they also have a high exposure. This is very important. So it means whenever you are taking a history of a patient who is having a COVID-19 or you are suspecting COVID-19, simultaneously take the history of to whom along with you are working, to whom along with you are traveling, to whom you are meeting, and to whom you are with living in the same household, because they are also very, very important whom we have to screen or they have to be home quarantine. This is very, very important as far as close contact is concerned. Next. Now, we are presenting some of the papers which were presented by in JAMA, in world leading journal, and this is one of the paper from the China itself, where 138 hospitalized patients with 2019 novel coronavirus infected pneumonia in Wuhan, China. The median age was 56, but if you see the 75, they were male. So 54.3% patients were male. In India, it is more with the male patients in compared to female. The hospital-associated transmission was suspected as presumed mechanism of infection for affected healthcare professional and hospitalized patients. So these patients who are already having COVID-19, they have infected healthcare professional or other hospitalized patients in 12.3% of the patients. The common symptoms was fever. The fatigue was also very common. So fatigue was 69% of the patient, and dry cough was also 59.4. But fever was, you can see here, it was in 98% patient was having a fever. Now, what was the blood count? Which is very, a lymphopenia. So it's not like a leukocytosis. It is a lymphopenia which was there in 70% of the patients. Prolonged PT and elevated LDH in 39 patients. 1/3 of the patients were having LDH and 58% of the patients were having prolonged thrombin PT, prothrombin time. Next. One more paper of the same patients who were CT chest was done, which was showing the bilateral patchy shadow, a ground glass opacity. So which is a very typical of CT scan of a patient. So by just doing a CT scan, it was almost like a diagnosis. Most patients, what they have done, what they have treated, they have treated these patients with a antiviral drug, which we were also using for a SARS. Many received antibacterial for secondary infection, which was quinolone, ceftriaxone, azithromycin. And some patients, 44% of the patients were given even steroid also. 36 patients, it means almost 1/4 of the patients, more than 1/4 of the patients, they require ICU for complication. And what was the complication? The complication was ARDS, arrhythmia and shock. I mean, the patient were having 30% of the patient were having shock. Arrhythmia was there in 44% of the patient, but ARDS was commonest presentation, and for that reason, patient was shifted in ICU, and that was acute respiratory distress syndrome. The median time from first symptom to dyspnea was 5 days, to hospital admission and ARDS almost took 8 days. I mean, once the patient who was having a first symptom, after 5 days there was a dyspnea, hospitalization was required for 7 days, and median time for ARDS was on 8th day. Next slide. This is the typical of CT scan in this novel coronavirus 19. You can see here a 33-year-old female whose CT scan was done, not enhanced. Image shows multiple ground glass opacity. It is in bilaterally there in both the lungs. These ground glass opacities are seen in posterior segment of right upper lobe and apical posterior segment of left superior lobe. The image obtained 3 days after follow-up shows progressive ground glass opacity in posterior segment of right upper lobe and atypical posterior segment of left superior lobe. The bilateralism of peripheral lung opacity without subpleural sparing are common CT findings of this novel coronavirus, which is been there in 2019. Next. The patient who were treated in ICU, while those patients who were not treated in ICU, you will see that the patients who were having more comorbidities, it means the patient who had gone in ICU, they were elderly in compared to the patients who were hospitalized. I mean, averagely patient who were hospitalized, what was the median age was 56, while here the median age was 66. It means even though who were hospitalized, but those patients who had gone in ICU were slightly older. But one very important thing, those patients who were require ICU hospitalization, most of them were having comorbidities. And what was the commonest comorbidities were the patients who were either diabetic, hypertension, or history of cardiovascular disease. Out of 36 patients who were in ICU, 41% of the patients required high flow oxygen therapy, and another 47% of the patients required ventilation. But there are few patients who were required even non-invasive ventilation, and some patients were required, only 4 patients which was required even a high intensive ventilation also. Out of these 47 patients, 34.1% were discharged and 6 died. So overall mortality was 4.3%. Those patients who were admitted to the death, but the remaining patients are still hospitalized among those discharged alive, and median hospital stay was for 10 days. Presumed hospital-related transmission of this novel coronavirus was suspected in 41% of the patients, and 26% of the patients received ICU care, and mortality was 4.3%. This is what the clinical presentation of those 138 hospitalized patients. But this does not mean that this is for all those patients who were hospitalized or all those patients who were having novel coronavirus infection. So, you know, we are seeing from different hospital, from different area, from different region, from different countries, the hospitalization for ICU requirement, for ventilation requirement, or even for mortality, or for the age of the patients are differently. A recent paper from Italy had come, the median age was like 80 years. So, I mean, those are elderly patients who are requiring only ICU requirement, or they died because of this novel coronavirus. Next. Now, what are the protective measures? Now, at present, we know that those patients who are getting infection, some of them are becoming serious enough to get hospitalized. Then out of them, some of them require even ICU care. And once they require ICU care, many of these patients may need even ventilation, and some of them are dying. So the protection is we should not get infection at all. That is the only way. And because it is with the close household contact, they may get infection. So somebody may be in family, maybe a young person who may get COVID infection, but he may be person who might be infecting his parents or his grandparents, and they may require hospitalization and they may require ICU and some of them may die also. So what precaution they should take? Wash your hands with soap and water regularly. This is very, very important. If once they wash their face after washing their hands, they should throw used tissue into closed bin, which is very important. They should not throw anywhere. If soap and water is not available, now this is very important because many of us are using just hand sanitizer. So if you are in clinic, in your place where the washing facility is available, please use soap and water. That is best in compared to the sanitizer. If you don't have, then definitely. For any patient, for publicly or anywhere when they are sneezing, they should keep the tissue paper. I will not suggest more of a handkerchief because the same handkerchief they may use again. So the better they have either tissue paper or they should cough with the uh, arm which is bent. Or they should wash hand continuously or multiple times whenever they get a chance or before touching their eyes, nose and mouth, which is very common habit with most of us. We keep on touching. So the best choice with us is washing hands multiple times. What I'm doing is I put my mobile on an alarm on every 1.5 hours to 2 hours just to wash my hands. Avoid mass gathering and crowded place, which is a social distancing is very important. So now I will not talk about mass gathering and crowded place because it has not to be there in a lockout situation. But even going for a normal walk in the society, not going outside, definitely, or even there also, don't meet anybody. No two persons should meet. Rather, you can do one and one only. So only single person should do. Next slide. So we had shown here that how the washing is to be done, but I'm sure all of you must have seen. And this slide you must share with your patient, must share with your relative, must share with the layman that how washing is to be done. Even the government of India and MOH, they are doing advertisement continuously on newspaper, on electronic media, that how washing is to be done, because washing of hand is very, very important, particularly interdigital space, which is very, very important, and we should wash properly. Next slide. Now, this is where we had put our RSSDI guideline also, that how to take care of yourself. It means healthcare professional, how they should take care of themselves. We had come out with this guideline. Even IDF had also come out with the two guidelines, one for the layman, one for the patient. Same way, RSSDI had also come out with a patient's guideline as well as for the doctor's guideline. But there are, again, the healthcare professionals are divided. One, those who are at front line. It means they are taking directly, who are COVID positive patients, they are taking care of them. And then there are physicians or clinicians or a primary care physicians who are treating in their OPD setting or in an emergency setting in a hospital where they are dealing with all type of patients. So one, for all those who are running hospitals, because there are some state health had asked all the physicians to continue their OPD at least for 2 to 3 hours. So one thing they should do for all those patients who have cough and fever, they should be seen separately and they should be seen in emergency. So as soon as you have a patient, first and foremost thing, each and every patient who is coming to this clinic or into the emergency setup, they should have a telephonic consultation before coming to that place. So, you can decide what type of patient it is, number one. So when you have that type of patient, the keeping safe distance is very, very important. If you have already a high suspicion, you can straightway send that patient to the a COVID-19 specified hospital or specified OPD, or the municipal corporation when they have designated place that you send these patients for if you are having a high index of suspicion. So like I am using a app which we can save which we can send to the patient, that you can use, that where you come, if you are coming in a range of medium to high risk, please get so and so investigation, or before coming to the clinic, you can talk to the patients and you can send the patient accordingly. But those patients, even though they may come and directly on walk-in patients, you should consider as a doctor that all patients who you are seeing, they have COVID only. So all those protection and all those healthcare measures are to be taken care. And those patients, those doctors who are visiting the homes for elderly patients, they should also take care all those healthcare measures which are provided, and they should see that these all are COVID positive only, and you should take care of yourself in that situation too. Next slide. Now, diabetes and COVID. This is an important question because I am dealing with diabetes, and most of my patients with diabetes also have, a lot of patients have URTI commonly, and they may have cough also. So as I told that I try to contact all of them, and those who are trying to contact my clinic, that's the reason I am there in clinic. But we are just treating all these patients digitally or e-consultation. We don't call the patient in my clinic, and just we are treating them on telephone, on video call, on FaceTime. And we see even a patients of diabetic foot also regularly. I'm seeing them on a FaceTime, and then we straight send them to the hospital if they need it. And that is what we have done in last almost 2 weeks. So the current problem is we can't see them also often. Physical examination is not possible. There are patients of type 1 or insulinopenic who are more prone to develop decay, maybe because of stress, maybe because of they may not get insulin supply. And what we have done from RSSDA nationally, that all patients who are not getting access or they don't get the insulin properly because of the supply problem, maybe because of the some of the medical store may not have it, we had made a free helpline. And this helpline is we have done to all our members across the country, more than 8,000 mail we have done, and all those API members along with that in a social media, and all those NGO and foundation who are type 1 diabetic patients foundation, we had given them so they can take the they can call the patient, the helpline, and they can get their insulin. We had also done a similar type of thing for glucose meter companies, for strips, for glucose meter, for continuous glucose monitoring, for intermittent continuous glucose monitoring, for pump supply, and for insulin syringe also. So, and diabetes is a condition where they have to take their regular control also. So they have to monitor distantly. They have to take care of their sugar. They have to see their sugar is not very much uncontrolled. Otherwise, they are more prone to develop not only infection, but once they develop infection, they are more prone to develop even hospitalization, or they may develop even acute complication too. So if glucose control is poor, the risk of complication and viral illness becomes high. And once they develop viral illness, rather the sugar increase is also very, very high. Next. So once they get admitted in the hospital, or once they are not getting admitted, so I am talking patients who are not having any infection, but they have to do their frequent monitoring, neither to go in hypo nor for hyperglycemia. A good glycemic control is lesser for that. Patients who have already existing heart disease, kidney disease, they are more prone to develop more complication. And these are the patients, once they get hospitalized, if it's a mild problem, they may continue with their oral anti-diabetic agents, but once it becomes moderate to severe, many of these patients are to be shifted from in-hospital hyperglycemia guideline, which we have. It has to be on basal bolus therapy, and once they are in ICU, it has to be only on IV insulin. But don't forget that nutrition is very, very important. They should not be only on glucose. We have now many of these nasogastric tube feeding formulas which are available, and regularly those patients who are staying at home at present, they don't have any infection, they should keep not only a good glycemic control, but also they should take care of their diet, because they are staying all the time at home, and they may develop they may eat more, they may have high sugar, they may increase in the weight. So they should do regular exercise at home. If they can't go out, they may do some exercise, yoga, all those things which can be done at home. And regarding the vaccination part, because just before in one webinar, somebody was asking, can we do the vaccination? If those patients who are not infected, and if they have not done their annual influenza vaccination or once in a lifetime pneumococcal vaccination, they can get their vaccine also. But at this point of time, we don't call the patient, because physical distancing or social distancing, which we want. So we always tell, once this lockout period is over, we will definitely vaccinate you. Next. So the timely blood glucose management is very, very important. And this is even recommended by different guidelines, whether you talk of American Diabetic Association, you had seen the ESD news, ESD paper also, and even with IDF also. And what we are looking for, that most of our patients are uncontrolled diabetic, and during this stress situation or during this lockout situation when they are eating more, their sugar may become high. And some of the patients even may go in hypoglycemia. And that is the reason the glucose monitoring is a key. And a good blood glucose management during this virus epidemic, I think, is urgently needed. And they should have regular supply of medication, regular supply of glucose monitoring device, and preferably a regular contact with their primary care physician as well as with their diabetologist. Next. Due to compromised innate immune response, diabetic patient exist increased susceptibility, as I already told you. COVID-19 with diabetes have much more potential to progress to infection with ICU, with more complication, with multiple organ failure. And we had seen some of the data that diabetic patients require more ICU care in compared to the patients who are not diabetic. Next. This I had already told, it's 4 times more, rather 5.9% to 22.2. Clinical data had shown the mortality from 2.3 to 15%. You can see 7 times more mortality. Even a diabetic patient itself have high chances of dying. So high chances of getting infection, high chances of getting hospitalization, high chances of getting ICU, high chances of getting ventilation, high chances of getting the complication, which is a shock or ARDS, high chances of mortality also. And the largest epidemiological investigation of China indicated that mortality with COVID is 7.3, which is dramatically higher in compared to 0.9%. So when they have done for complete data, it was 0.9%, while the patients who are having diabetes had 10 times more, almost 8 to 10 times more chances of dying. Next. So all chronic patient, I'm not talking only of diabetes, but diabetes is one of the important. CVD itself is a very, very important condition. These are the patients also have high chances because patients with a underlying cardiac condition, if they develop myocarditis, that is one of the presentation with COVID, they will have high chances of mortality. Diabetes comes second, chronic respiratory disease, hypertension, cancer, and some of the patients may have multiple things, may have diabetes, may have CVD, diabetes with respiratory problem, diabetes and hypertension. We have many of our patients combined and commonly, so they will have more problem and they will require more hospitalization and ICU care. Next. Older patient, this is one interesting data, but this is from all over the world, where 80 plus, we don't have many patients from 80, but we have many patients who are above the age of 60. So what we had seen in India in compared to other western part of the world, where 80 plus is also very commonly present and they have more problem, while here we are seeing even more than 65 or 70 also have higher issue. And this we had seen in this graph also, the younger population which is below the 50 have less chances of fatalities in compared to the patients who are above the age of 50. Next. Now, why? I mean, what could be the reason? The hyperglycemia and all these things. One of the important is a triggering factor is stress. We know that stress leads to counter-regulatory hormones which are released, which is glucocorticoids and catecholamines, and this results in elevated blood glucose and abnormal glucose variability, and which leads to more of diabetes complication. Next. So patient with diabetes with this coronavirus infection. Now again, hospitalization, at present we are hospitalizing all patients, but as per WHO, there are patients who are not requiring hospitalization with coronavirus and requiring hospitalization, but all those patients require good glycemic control. And I am putting for a blanket statement, all diabetic patients should have a good glycemic control, may not be only with COVID or with any infection. In follow-up period, the patient sugar report has to be again under very good control. So those patients, whether in a hospital, whether they have developed infection, whether they are in ICU, their good glycemic control will change their outcome. This is very, very important. And this timely blood glucose management, which we are looking and we are talking on, is very, very important key message for all of us. And I think that will help our diabetic patients to have less morbidity and less mortality. Next. With the smartphone, with the internet which we have, not only we are doing a lot of webinar, we are doing a lot of talking to each other and virtually we are meeting, and we are going to have even virtual meeting also, which we have done today, and from day after tomorrow, from Sunday to next Sunday, almost like for a Tuesday on 14th, we are going to do 10 such meetings, which is what we are going to do. So on this, on a telemedicine, what we are doing, we are talking to all our patients, and not only that, this remote medical consultation we are not only doing for our OPD patients, but we are also doing this remote medical consultation for all my hospitalized patients who are hospitalized under the care of infectious disease specialist or with intensivist or with pulmonologist. But I am tracking all those patients on telephonically for their sugar reports. Either I may be talking to their nurse, ICU nurse or hospital nurse, or to their doctors. And at the same time, we are also doing chat on different digital media to improve our knowledge, to understand more about this disease, and simultaneously to know more about diabetes. That is our primary subject. So we are utilizing really this time for improving our knowledge, and so we can improve the care for our diabetic patients. Next. There are some unproven therapy, but at this point of time, you cannot say that they are unproven, because some of them were used in some of the clinical, because at this point of time, we can't do a prospective clinical trial, but whatever they have done and whatever they had used, they had shown some data with hydroxychloroquine, with chloroquine, and that's how it had come in a prophylaxis in India also for a high-risk patient. Then there was a in between AC inhibitor and ARB, what we should do. But then American Society of Cardiology and European Society of Cardiology had come out with a guideline and a statement that we should not stop AC inhibitor and ARB. Then in between there had come with the DPP4 inhibitor will be protective, but at present we don't have any comment on it. We don't have any data for it. So we are not putting it. So I mean, these are, you can say that these are the therapy which are evolving, rather than I will say unproven therapy, because ultimately a patient who is dying and we are using different type of molecules, and some of them are showing some good results too. Next. This is a article which is published from India. I will say one of the earliest article which had gone for a e-poster on coronavirus from India, and I must congratulate the Vivek, who is from Goa, and other doctors from all across the country who had reviewed an ongoing trials which is evaluating the diagnostic and therapeutic intervention to manage this respiratory infection caused by 2019 novel coronavirus. Next. There is one more, World Federation of Intensive and Critical Care, which is the on a knowledge, awareness, and attitude towards COVID-19 among caregivers, along with patients in an outdoor patient setting. Now, this is a questionnaire-based paper is being published, where Dr. Jayashree is going to publish. And what we have done is simply a knowledge, awareness, and attitude towards this COVID 2019 with caregivers and what patients, what they are thinking. Next. The mental health of the patient is also becoming really an issue, because in Wuhan, they had to stay in the ICU for a long period of time without taking food sometimes, and with a lot of emotional issues, because many of the patients were dying in front of them. They were having themselves anxiety, and they were depressed also, and they were worried about themselves whether they will get infection or not. So I mean, all these issues had really caused a lot of mental health issue in the patients, in the healthcare provider, those who were treating the patients in Wuhan. Next. With this, I would like to thank all of you, and once again thanks to Sanjay, Precia, and Vinod Mishra and complete team of Precia, Manoj locally, that it's very important at this point of time that we should talk about diabetes and COVID. But I'm sure in coming days, in next 10 days, we may do again similar type of webinar where we can discuss something else other than COVID, or how COVID is changing our diabetes patient treatment, how we are dealing with our patients who are distantly monitoring, how we are dealing with them on telephone, and still whether we are really getting their good results or not. And probably maybe after 2 or 3 months or 6 months, we will get all those patients who we have treated them during this COVID period of time on telephonically, whether their sugar was better or worse in compared to those patients who are coming to our clinic regularly. So that difference also we will able to produce, and we will able to put our paper in coming years. Thank you. Once again, thanks to all of you.
Thank you very much.
Wonderful, wonderful deliberation, doctor. I think excellent presentation and deliberation by Dr. Bansi Saboo. I request the audience to ask the questions now, because the schedule was first for the speak and first for the lecture, and then there was a question and answer. Please unmute yourself. I request all the participants to open up their video as well, so we can see them, and they can be also seen by Dr. Saboo, and we can take the questions now. Any questions there amongst the participants? Dr. Nagar, you would like to add something?
Very deliberate talk.
Yes, sir.
Get my voice?
Yes, yes, tell me.
Yes. Bansi bhai, thank you very much. It was a nice talk.
Thank you, Jitendra.
Yes, yes. And irrespective of type of diabetes, I think only one thing is there: preventive measures.
But
We
that is there
remain
because that
isolated.
is always there. But you know, Jitendra, I've seen a lot of issues related to type 1 diabetes. And luckily,
Yeah.
what we have done before even 2 weeks, because when I
Yes.
came from outside, in the first week of March itself, when we had realized that this will become a big problem. You know that we are running 12 sub-centers, and I have more than 2,000 patients who are taken care in my center. And we have 800 patients type 1 to whom we are giving free insulin. So what we have done, we immediately called all our type 1 diabetic patients by telephonically. My 15 or 20%, they were calling them, we were messaging them, and we told them, you please collect your insulin for next 2 months. For March and April, complete supply should be there with you, including glucose meter and strip, because 800 patients, we are giving them free of charge. And then I have patients from South Rajasthan to MP, and all those patients, we have messages. And then all those type 2 diabetic patients, we have done a message on 10th of March. You please don't visit. There is no need to come to Ahmedabad, because travel unnecessarily will increase your anytime any is there. You please call us. We will take care of you. And then onward, we just stop and decrease our OPD timings also. But we were talking to all our patients regularly. And still today, you know, I have come here at 10 o'clock and I go every day by 6 p.m. So 8 hours a day, almost like every day 20, 30 patients, I talk to them. And in between, we do all webinar and reading and all those things. So 10 to 6, I am here trying to take care of many of these. So I mean, a type 2 diabetic patient or even a type 1 diabetic patient, if he feels that my doctor is just one phone call away from me, he is comfortable at home. And I think this social situation and in this health situation which is prevailing in India is really making our patient more comfortable compared to Western world. In Germany, in Italy, in Spain, in US, they are really getting difficult time because they can't talk to doctors so often. They don't get pharmacy like wherever they go and they can get their medicines. Again, their insurance issue also comes in between. Here they have to pay from their pocket. So they can go to any pharmacy and they can just buy the medicine. Yes, we know that there are many pharmacy might be changing the medication, but at this point of time we allow. Even suppose some patient might be in some combination therapy and patient, you get a call, you just tell that this combination consists of these 2 molecules. If you have a combination of other companies, fine. Otherwise, you can give these 2 medication or 3 medications separately, but please take care. And third, I learn more because many of our patients, I used to tell them about the self-monitoring of blood glucose. And now they are realizing the real importance of self-monitoring, because when they are monitoring themselves at home, they can call me or they can call my clinic and we can take care of them. If you are not monitoring, how I am going to help them? So the self-monitoring is really helpful of our patients.
साबू एक वाला क्वेश्चन है,
बोलो।
ये अभी हमारे 2400 मामले हुए हैं इंडिया में. I know it is not relating to what presentation has happened, but you have also become the chairman, president of RSSDI. इसके आगे क्या situation रहेगा इंडिया का? When you see that
the last
pattern
call, which was before the lockout, you know, uh, Pradhan Mantri Sri Narendra Bhai Modi also talked to almost all major associations of country, including their president and secretary, and I was one of them. So the API and even Critical Care Society and Medical Society and Anesthetic Society and many of them, but it was more of a motivational talk. But if you just see in last 15 days, whatever the data we come from WHO or ICMR, it shows that the first 14 days definitely this lockout period will be there, so which is there up to 14th of this month. Then they may do a lockout in a particular areas or where there is a high index of suspicion on all those patients who are already their patients and some type of places where a lot of crowding is happening, or they may see after 7 days or 8 days or 10 days with after the partial lockdown how the situation is deteriorating or improving. Accordingly they will take the second call whether we should go again for full lockdown or we should do only partial lockdown for another 2 months. But I think over a period of next 1 or 2 months, we have to be consider ourselves that we are dealing with a lockdown situation or like a partial lockdown situation where only essential services will be available to us, and most of the time we will be either at home or we will be only digitally talking to each other. So physical distance and social distancing will be maintained.
Thank you very much, sir. Dr. Vismay has a question. Dr. Vismay, can you just ask the question, please?
Yes, sir. Hi, this is Dr. Vismay.
Yes.
Can you hear me, sir?
Yes, yes, very much.
Okay. So with this COVID-19 infection, we have just opened up another aspect of diabetes, which is the immune function. What do you think are the strategies? Just as we have the molecules which can improve the cardiovascular function in diabetes patients, but what about the immune function? We all know that diabetes has reduced immune function, but what we can do to address that thing?
So yesterday
What do you
I
think for
was with the one webinar and one group which we were doing a national meeting with controversy in diabetes and hypertension, where Itmar Raj was from each country. He was taking one. I was one of the experts from India, and where Ralph Differenjo had talked that at present we don't know that immune reactions in a diabetic patient is a different than other patients. So the immune reactions of a diabetic patient is really different in compared to the patients who are non-diabetic. But what he had postulated, which is Ralph Differenjo postulate, it means we all have to think it. He is saying that because of COVID virus infection, probably we will see more autoimmune diabetes in coming years. This is what he is expecting. That not only type 1 diabetic patients will increase, but LADA patient, which is in young age, we will see, because actually virus is responsible for autoantibody formation in our body, and probably we will see a lot of autoimmune. So not only autoimmune diabetes he was talking, lot of other autoimmune diseases we will be seeing in next coming year or in a decade, because this infection is all the world. It's not like 1 million persons are infected, but these are the diagnosed patients. Probably we may have many more, or maybe after 2, 3, 4 millions or hundreds of millions, if they are getting infected in coming years or maybe in coming months, we don't know what will be their immune reaction and how many autoimmune diseases which we are going to increase in coming years. So that was what postulated by that. But at present, we don't know that immune reaction in a diabetic patients who are going to ICU setup, ICU caring, is it because of that they are dying more, or because of diabetic patients or a respiratory patient or heart patient, they are dying more because of their comorbidity? We don't have any explanation.
Sir, Navneet here. First of all, very nice lecture, very comprehensive yet elaborate. I think this is a very valid. I was going through some literature from the Spanish flu, historical perspective. Are we going the Ebola way? Where it will land up? Because I think this is a juncture where acute condition has made the chronic condition more challenging. During 100 years back, diabetes was not the concern. Acute was the one. I think this is a very valid thought what you have brought forward. Autoimmune diabetes, perhaps minuscule, maybe a little bit more prime area.
And not only autoimmune, it is all autoimmune condition will increase.
Yes,
because millions
yes,
of persons are infected with a virus, what will have their autoantibody formation, how much they will have. It is really thought by scientists all across the world, and we are thinking
Yes.
maybe in coming year or decades we will have more autoimmune disease.
Yes. Very nice.
So one another question I have is, there is a palpable sense of panic. I would not, there's a fear amongst the diabetes patients as of now. And we as in healthcare professionals, we are at the front line to guide them not to panic. That is the first thing. And we have also come across recent papers from China that after COVID-19 infection, they have done a psychological survey of the patients, and there they have seen not just patients but the doctors. There was almost 20 to 30% increase in the rates of insomnia, depression, and anxiety disorders.
So, I mean, what you are saying is perfectly right. There is no doubt about it, because when such type of pandemic is happening, even you and me also can go in a depression. So, I mean, if we are busy doing so many work and doing so many things, otherwise somebody is sitting all the time 24 hours and chatting on the telephone and he's seeing a lot of negative news, he may go in depression also. So that's
Yes.
true. Now regarding diabetic patients, because there is a lot of noise level which is increasing amongst physicians and doctors that diabetic patients are more prone. But what I tell my patients, diabetic patients, if you have a well-controlled diabetes, it means you are equivalent, to any other person who may have also infection. But definitely, we know that diabetic patients even getting admitted more, elderly patients more getting admitted, and they develop more complications also, and their death rate is also high. But I think we had come out with a RSSDI guideline, not only for healthcare professional, we had also come out with a very nice document guidance for the patients too. So, one that nobody should become panic. It's like when morning our Prime Minister was also talking that we all are together. We may be distantly talking only on telephone, but all of us, 130 crores, are together, and we are fighting together for this against this pandemic. So I think we should give a reassurance to all our patients who are talking to you, and you just tell them you are fine. There won't be any issue, and don't worry. And anytime, anywhere, whenever you have any problems, I am one call away from you. So this itself makes your patients very much comfortable. If you just tell your patient, whether he's calling you from Rajasthan or calling you from 2 kilometers away from you, and you just tell them, oh, don't worry, I am there for you. What is the problem? Just see the problem, explain the patient issue, and it is taking definitely too much time. We understand, and many of the times, 90% of the time, we are not paid for it also. But it's okay. We are really helping the society. We also feel proud that at this point of time and this, any situation, they are calling you, and you are the one who can reassure them, and you are serving the society, your patients also.
Sir, I must congratulate you, across all therapies. As a RSSGA president, you have been the first one, irrespective of critical care. None of the specialties could bring out those documents, and that too, one for the patients, one for the healthcare providers. It is so unique and distinctive in our country. As the numbers were going before even that, that documents were really out. That's a
And
very
we have
leading
taken
step.
all references from WHO, ICMR, and the hydroxychloroquine issue, everything we have included. So it was
comprehensively and at a very fast pace, within few hours.
Many of us were working, and really document had come very nicely. Our Srinivas Murthy and Sujoy Ghosh must be given special thanks. And then our Pratap Jetwani from Gujarat also, K. Sharma.
Very well, sir.
They had worked also very hard. And then Sanjay Agarwal, who are Honorable Secretary. Because of that, we could come out with this nice document. And we have taken also the AK Singh had given just before some time, he had come out with a paper on a hydroxychloroquine. So we have included his paper also. And he was also our reviewer for this document.
Mammoth work, sir. I think we congratulate kiya jaye kam hai. I think as you said that
every day we take one project.
Yeah.
See, yesterday the glucose meter strips, that free helpline we had created. Every day we do one project. And since last 10 days, something or other is getting out.
That's great. Sir, there was one couple of more questions. I request
Yes.
audience because some people have the phone name only. So we have one question regarding hydroxychloroquine. Sir, can you just ask the question?
See, for hydroxychloroquine, I must tell you, the document is very, very clearly written. And ICMR had put the advice very clearly, and I am sure all of you must have must have received that document on your WhatsApp group also, and in WhatsApp message also, which is hydroxychloroquine is primarily for a prophylaxis only for a high risk individual. And who are they? One is healthcare professional who is directly dealing with COVID patients. So like me and Jitendra, who is sitting in his clinic and not seeing the than diabetic patient who is a COVID patient may not take it. Number one. And all those healthcare professionals, not doctors, even the nursing staff and all those who are taking care of COVID 2019 patient in hospital, they must take as a prophylaxis. Other are the patient's relative or the persons who are already directly exposed with the patient. Now, if suppose tomorrow I am seeing a one patient and patient found to be a COVID 2019 positive, then even I am was not treating him directly, but indirectly I am directly exposed, then it can be also given as a prophylaxis, but not for everyone. So even though we are giving to the high risk patients, we also see what is their underlying condition. Suppose they are diabetic, we know that hydroxychloroquine is also an anti-diabetic agent. And when you are treating them with sulfonylurea and insulin, there is a possibility this patient may go in hypoglycemia. Hydroxychloroquine might increase the QTC interval. So if I am giving some other QTC interval increasing agents, there is a possibility of slightly further increase in QTC interval, and particularly the patient with the established cardiovascular disease, at least I can omit some of the molecules which also increases the QTC interval if I get a chance to consult these patients. I mean, this is what we are doing, and this document had come very, very clearly and nicely documented by ICMR, and in our RSSDI document guidance also, we have written this with the proper references too, along with the review article which was also published by Anup Mishra and group.
Great. Dr. S.V. Kulkarni is there from Mumbai. He is also one of the author of that paper which you have shown. He would like to participate and make
Bansi, fantastic presentation. Can we invite all the
You are on.
कुलकर्णी सर आपकी आवाज जरा नहीं आ रही है.
Am I audible? Am I audible now?
You are audible.
Yes, now you are audible.
See, use of technology is going to make a lot of change in diabetes management at this scenario. Can we ask the CGMS people to reduce the cost of the CGMS instruments? Because that is one thing which can help all our diabetic patients to achieve the target and maintaining within the time range. I think
Kulkarni sir,
yeah,
you know, I'm very, very proactive in this work, and we are talking to many of our these companies also. At present, immediately they may not do it, but continuous glucose monitoring which we are using in India is a intermittent CGM, which is Abbott Libre Pro,
right,
and which cannot be used in this situation because the patient cannot buy the monitor by themselves. Unless we get a Libre in India, this is of no use. Dexcom is very, very costly. When they reduce their price, still it will be very, very costly. Then the third thing which had come in India is Medtronic. Again, Medtronic have a connection with your iPhone also, but still the cost of that instrument is also very, very high. So at present, what I am recommending, and now recently we are also talking to many of our glucose meter company, that distant monitoring and self-monitoring of blood glucose itself is very, very essential, very powerful tool, and many of our type 2 diabetic patients can achieve a relatively good glycemic control. I will not put a tight glycemic control, a time in range, but a good glycemic control with regular monitoring. So all my patients, we regularly advise for monitoring. Now in this particularly this type of difficult situation, we are talking to them, why don't you monitor and send this? Like they can do alternate day or once in a 3 days fasting sugar, alternate day post breakfast, post lunch and post dinner sugar. this 4 sugar report, if you get in a patient from in a week or a 2 week, you will averagely get that where patient is going. If patient is uncontrolled, he can monitor more frequently. If patient is going in hypoglycemia, he can monitor more frequently. Patients are on insulin, hypoglycemic unaware, patients with a established cardiovascular disease, patients have nocturnal hypoglycemia, they can monitor more frequently in compared to the patients who are on agents which are not causing so much hypoglycemia. So this guideline we are making like this because at present the cost of monitoring device is very high, CGM. Even if they come out with a, from suppose Dexcom is costing almost 100,000 rupees in India. If it comes out with 50,000, still 50,000 will be very costly for patients. So I don't think at this point of time we should ask for them, but we are telling them to reduce the price for some of the patients who are really in need of it, mainly like type 1 diabetic patients and some of the patients who really require intensive monitoring.
Great.
Any specific glucometer you will suggest can
Not
be
specific, because I should not, again on this platform I will not name anyone, but those top 5 companies, today I had put in the social also, these top 5 companies who are selling in India glucose meter, not only I had put their name, their helpline number and their glucose strips, it is available, along with insulin syringe, Medtronic continuous glucose monitoring, Dexcom and Libre Pro, along with this Ypsomed and Medtronic pump supplier also. So I mean, I had put a tabular form the helpline number of all these companies, and so across the country, those patients who are in need of it, or they don't get the supply properly, or their pharmacy they don't have, they may call these helpline number or toll-free number to get the these strips, or it is insulin also. So
nice.
other table I had
So
put
nice
the
of you.
insulin
Thank
table
you.
also.
Thank you. So nice of you.
Dr. Bansi sir, thank you very much. I express my sincere gratitude for sparing the time from your busy schedule. And at Precia, we are really grateful to you for enlightening the audience today. And I'm sure that this deliberation would have helped many to have the clarification onto their common queries. So once again, I thank you, audience. I thank my team at Ahmedabad, team at Mumbai. I thank all eminent doctors who have joined. And above all, Dr. Saboo, aap hai to bahar hai.
Thank you.
Thank you very much, sir. Thanks a lot. And be safe. And looking forward for more and more from you.
Thank you, sir. Thank you.